Today, I would like to talk briefly about the role of occupational therapy in the management of diabetes. So our objectives, the goal of this presentation is to define occupational therapy, describe how occupational therapists serve our patients, and to discuss where to send referrals. So let's quickly define what occupational therapy is. Occupational therapy, the practice framework, defines occupational therapy as the therapeutic use of everyday life occupations with persons, groups, or populations for the purpose of enhancing or enabling participation. OTs specialize in helping patients live full, healthy lives through the engagement in valued occupational tasks or activities. An occupational task can include anything someone might want to do, like getting dressed, going to work, cooking, spending time with family members, or managing their medications. We use these occupations as the foundation for our treatment. So for example, for our patients who have to manage their diabetes and may be struggling to do so, the occupational therapist will use that occupational task of managing diabetes as the core of their treatment plan. So essentially, occupational therapists use a client-centered approach and the task itself to create to increase a patient's participation and success during a valued task. Okay, next slide. So what do I mean when I say client-centered? Well, occupational therapists are trained to analyze a patient's environment, their habits and roles, and their strengths and weaknesses, and then utilize that information in conjunction with what we call a task analysis. A task analysis can be defined as breaking down a task and defining the different elements required to complete that task. For instance, how much strength is needed to lift a box? Do we need 2 people? Do we need a tool like a dolly? So for our patients with diabetes, an OT would identify all the different contextual barriers and strengths specific to each individual, and then utilize that task analysis of, let's say, organizing their medication in order to develop a treatment plan that will enhance and increase their success. Okay, next slide. Okay, so let's take a look at an example of a patient who you might run into. Mrs. Thibodeau has come into the clinic for a follow-up for her type 2 diabetes. She had a stroke about 2 years ago and still complains about some residual left upper extremity weakness. She lives with her husband in a 2-story older home, and she's been inconsistent taking her medication, and she mentions during her visit that she just finds taking her medication frustrating, and so she often won't take it. Further questioning reveals that Mrs. Thibodeau is struggling to open her pill bottles at home ever since her stroke. An occupational therapy consult would be a good resource for Mrs. Thibodeau in this scenario. The therapist would do an assessment of Mrs. Thibodeau's medical history, her physical strength, her environment, and her cognition. So during this evaluation, let's say the occupational therapist discovers that not only is Mrs. Thibodeau struggling to open her pill bottle, but that she's also demonstrating some memory deficits we didn't realize she had, which limits her ability to schedule out her medications. The therapist may also note that Mrs. Thibodeau's home environment is a bit cluttered and unorganized, and Mrs. Thibodeau is frequently unable to locate her medication. Maybe Mr. Thibodeau typically stores their medication in their bathroom upstairs, and Mrs. Thibodeau typically doesn't go upstairs anymore since her stroke. With all of this information in mind, the OT will work with both Mrs. Thibodeau and her husband to create a schedule and a strategy for taking Mrs. Thibodeau's medication. Maybe they will provide timers or a pill organizer, suggest storing medication downstairs. We might work on Mrs. Thibodeau's upper extremity strength and dexterity to make opening the bottles easier and less frustrating. Or perhaps provide a modification for opening the pill bottle, like Thysom. We may work on memory strategies and cognitive exercises to help Mrs. Thibodeau remember to take her medications daily and to remember where her medication is stored. The OT's role in this simple example is to identify all the barriers that might be limiting a patient's ability to participate in an important and meaningful occupation that perhaps even the patient didn't recognize was a barrier to success. And this also applies to any patient who may be experiencing a barrier to participation in any valued activity. In addition, the occupational therapist will identify and enhance a patient's strengths, such as having a supportive family, inherent motivation, and the ability to adapt, which all could help the patient succeed. Okay, next slide. To wrap up, I'd like to talk about how to refer your patient to occupational therapy services. So first, I'd like to talk about outpatient services. Any outpatient therapy facility that serves the adult population and staffs occupational therapists would be a good place to start, especially if your patient is able to navigate the community well. OTs in private practices are a little hard to come by, but often hospitals with an outpatient therapy department will likely staff OTs. If your patient is considered homebound, then of course, home health services are the way to go. And qualifying for home health services under Part A Medicare is the typical way patients get referred, especially after returning home from a hospital stay. But a lot of home health companies are also picking patients up under Medicare Part B and are able to send therapists to patients' homes with simply a referral from a physician. And lastly, there are occupational therapists nowadays setting up camp in the primary care world where they work at a physician's office and can provide services right after a checkup next door. This is very rare, but it is something that is developing and it's quite exciting. Okay, and that is all I have for my presentation. Thank you all so much, and I will turn it back over.
Great, thank you, Kelly. Thank you so much for providing all the details, and definitely I like the white glove, as Christine said, for occupational therapy. That's great. So I think we struggle always, you know, what will they help them with? Is it physical therapy? Is it occupational therapy? So I think a lot of people just send them your way and you figure it out kind of thing. So wonderful. Thank you so much. Does anybody have any questions for Kelly before we move on? Okay, great. So I will go ahead, and you could ask any questions in chat or once I'm done as well. This is kind of, two of us are doing similar details, and so we could also ask questions at the end. So my talk is titled Know Your Audience, and I really enjoyed this topic because we just have to think individual. Otherwise, we're going to have a cookie cutter approach that's not going to work more than half of the time. So kind of my objectives are to when you walk away from this talk is to kind of think about personally diabetes treatment goals while considering patient goals and your goals. So just because I want your A1C at 7 doesn't mean your goal is A1C at 7 for whatever reason, right? So you got to kind of find that middle ground. Personalizing medication choices in diabetes, that's going to be must. There's a lot now. Personalizing recommendations of resources and tools, and then personalizing planned care overall. So diabetes is just one piece. Everything else needs to be kind of included. And the next slide, I kind of made up this little graphic, and the red, if you start at a point X and you want to get diabetes under control, whatever that means, the red is really kind of, not everybody should be the same. It's not personalized to just kind of have a template. The green is where I would like us to think when we think of treatment of diabetes. We have to think their age, their ability to do things. Do they have barriers? What kind of barriers are they? Do they have comorbidities we should include in this plan? Disability, engagement. Do they really care to engage a lot, or do they just say, you know what, I could do this only for morning and I'm done? Do they have funds? And funds, I just use this ABCDF, you know, kind of letter thing. Funds for, is it financially what's going on with insurance and so on. And then G for gadgets. Do they like technology? Do they even have a cell phone that's, you know, smart, fancy phone? So kind of just thinking about all of these things. And so on my next slide, I always want to remind us too, when we're talking about diabetes, it's not just type 2 diabetes, it's not the same. So there's type 1 diabetes, right? So insulin would be the main treatment, and then how do you deliver it? For type 2, you know, maybe early on in a younger patient, you want to preserve beta cell function, and then maybe later on, you don't have to think about that so much because, you know, the beta cell protection, they might be already on insulin, and so that's not as much of a concern. So you might use different medications. It's just gestational diabetes. There's different medications for that. Could it be that they have cystic fibrosis? So again, what are we treating? Then we decide on what medication. And next slide, please. So I do like this little graphic from American Diabetes Association, and they, if you focus on the red square up there, or a rectangle, the A1C of 7 kind of is what we standardly think of getting to, and we're going to do less stringent rules if there are different things, and I'll go through these, versus more stringent depending on what their situation is. So they're factors that we don't modify. So how long you've had diabetes, we cannot change, right? So we got to take that into account. We can't change it. Life expectancy, again, not really changeable, right, for the most part. Important comorbidities, if they're there, they're there. However, what we can change is patient preferences. We could kind of work on that and tweak that a little, or give them information to change their mind. Resources and support systems, so that we could possibly intervene, just like we talked about today. And then if you click one more time on this slide, other modifiable factors are activity, physical activity or inactivity, overweight or obesity, that could help mobility-wise, or glucose-wise, or diabetes, or blood pressure-wise, or whichever way. High blood pressure, smoking, cholesterol levels. So all of these we could modify somewhat. So again, think of, can I change this or can I not? And of course, focus on things that we can change. And I can't go through every single individualization thing, but a few that I'm going to focus on that I think are important. So monitoring glucose, as simple as that sounds, how do we do it, right? So we have different ways. We could check A1C, we could do continuous glucose monitor, we could check fructosamine and combine some of these things. And then of course, the best kind of immediate is the self-monitoring blood glucose, which I love and prefer, because it's the least one that you could alter or falsely increase or decrease, other than if you end up making up numbers, which most patients don't. And most of us want to be helped, and so we do the right thing. So A1C, again, this is the red blood cells that has a glucose attached to it. And so if you have less blood cells, or they're lasting shorter or longer, that's going to be affected. So maybe kidney failure or liver disease or anemia could affect that number. So if it doesn't make sense, then you go to self-monitoring blood glucose. CGM has its own issues. Fructosamine is actually a protein that's glycated. So if somebody doesn't have any protein issues, but they may have blood count issues, then I check fructosamine. That one to kind of to see if my self-monitoring glucose matches with this. So anyway, those are just some of the individualized approach ways to monitor glucose. And on the next slide, and again, Dr. Gadi pretty much covered all this, but goals, right? So if you have a 93-year-old with impaired vision, right? So these are going to be very different goals that you're going to have in mind, or what you're going to use, versus a 53-year-old tech-savvy person. A bunch of engineers in their 50s and 60s, and they want the latest and the greatest technology and stamp time, and I know what I took and when I took it and what graph goes up and down. It's wonderful. It's great, as long as they use it and kind of act based on those things. Or a 63-year-old with multiple comorbid conditions that has a needle phobia, right? So again, you take out half of the treatment for diabetes if they have to be on insulin, if they have needle phobia, or you may involve some sort of, mental health help to kind of get them over this hurdle. And then on the next slide, to go over even gadgets. So I just picked kind of a few that we may not be as familiar with. So glucometer for visually impaired, there's such a thing. So it's a voice activated one. Hearing impaired, there are certain ones that make noises if your sugars are low or high and so on. Or maybe they just need to get until they get hearing aid. Multiple injection devices. So this little device right here that I have a picture of is kind of interesting. And I learned this from a patient. He said, I have this little device that sits on me and I just take my needle into the device so I never feel a prick, other than when you place this device. And I think he said he places it once a day. And so he had 5 or 6 injections with insulin. And so this worked great for him. He didn't feel the needles. And so this is just one component. And then there are pens out there with timestamp and dose. So sometimes patients with dementia use these because they don't remember when they took the last one, but they know they need to be on medication and they know they use this pen. And so the pen will say, 735 on the 15 took this many units. And so they would know, hey, I only took it this morning, or I didn't take it this morning, so which is helpful. So these are just, again, some examples of how you would use this. And again, keeping in mind these comorbidities. So cognitive impairment is a big one, pancreatitis history, hearing impairment. And these are all common comorbidities with diabetes, right? Sleep apnea, um, any psychosocial factors, emotional disorders that may not help with this whole thing. And so just kind of keeping in mind everything else. And then this is my last slide, and I really do go to this a lot. It's a friend sitting in clinic on the wall. So when you think, what should I put them on? And you're rushing and you're kind of, gosh, what do I do? What's better, pioglitazone or sulfonylurea or, SGLT2s? This is a wonderful resource from ACE. And they show kind of the big ones. So if the patient is having hypos, which medications to do or not to do. If they have bone disease, maybe we don't do TZDs and so on. So this is a little bit kind of a nice table that tailors some of the stuff we talked about. And that's my last slide to accompany Kelly's occupational therapy. It's somewhat similar.